Welcome to Nursing Management of Patients with Renal Disorders, Nursing 200. The following slide shows the anatomy of the kidney and the vasculature system of the urinary tract. If you notice that the inferior and superior, the inferior vena cava comes down, and that the renal vein and the renal artery are inserted into the various vasculatures located within the abdomen. The left kidney is slightly higher and off to the back than the right kidney. Anatomically, you'll notice the ureters go down and insert into the bladder, the urinary bladder, and also note the position of the organs within the abdominal cavity. The kidney and urinary system changes that are associated with aging include the following: reduced blood flow to the kidneys, a thickened glomerular and tubular basement membrane, decreased tubule length, decreased glomerular filtration rate, which is a calculation that determines how well the blood is filtered by the kidneys, and the reduced ability to filter blood and waste products. This consists of reduced drug clearances, risk for drug reactions, kidney damage from contrast dyes and drugs, nocturnal polyuria, in other words, increased urinary output at night due to the decreased ability of the body to concentrate urine, and the risk for dehydration due to impaired thirst mechanisms in the elderly. Acute renal failure, or ARF, is when the kidneys excrete waste, water, salt regulation, and maintain acid balance and red blood cell production and blood pressure regulation. Acute renal failure is typically a reversible clinical syndrome in which there's an abrupt loss of kidney function and a GFR over a period of hours to days. So remember that acute renal failure is usually reversible when the underlying cause is identified and taken away. Acute renal failure often occurs when renal blood flow to the kidneys is significantly reduced or altered in an abrupt manner. Some of these types of things can be trauma and various other mechanisms that reduce the flow to the kidneys. The four clinical phases of acute renal failure include the initiation or onset phase, the oliguric phase, which is the phase where the urinary output drops, the diuretic phase, which is when the kidneys begin to recover and dump out large amounts of urine, and then the recovery phase. There are three different types of acute renal failure. One is pre-renal failure, where a sudden and severe drop in blood pressure, often due to shock, or an interruption of blood flow to the kidneys from a severe injury or illness, your traumas. The intrarenal is a direct damage to the kidneys by inflammation, toxins, drugs, infection, or reduced blood supply. And then your postrenal is a sudden obstruction of urinary flow due to an enlarged prostate, kidney stones, bladder tumor, or injury. And if you look at the slide, you'll note the corresponding numbers show where the areas that are affected, the kidney is affected by. Question: is the following statement true or false? An older adult with benign prostatic hyperplasia is at risk for the postrenal type of acute renal failure. The answer is true. Postrenal acute renal failure is the result of an obstruction that develops anywhere from the collecting ducts of the kidney to the urethra. This results from ureteral blockage such as bilateral renal calculi or benign prostatic hypertrophy. Phases of acute renal failure. The initiation or the onset phase is the precipitating event. It's the gradual accumulation of nitrogenous waste, and you'll see on their lab work an increased creatinine and an increased BUN. The oliguric phase is where further damage happens to the renal tubule or the renal wall. This results in an output of less than 100 to 400 milliliters of urine in a 24-hour period. During the oliguric phase, there is no response to fluid challenges or diuretics. Fluid challenges are when the physician orders a bolus of IV fluid anywhere from 500 to 1,000 cc's in an effort to increase urinary output by increasing volume within the vascular system. An increase in concentration of waste such as urea, creatinine, and electrolytes will be seen during the oliguric phase, so resulting in an elevated BUN, elevated creatinine, elevated potassium, elevated phosphorus, and elevated magnesium. And this is due to these products not being filtered out. Additionally, you'll also see hypocalcemia. The diuretic phase of acute renal failure consists of a high output where the source of obstruction is removed. Urine flow gradually increases and oftentimes rapidly, up to 10 liters in 24 hours. Electrolyte losses are followed by a decrease in BUN. During the diuretic phase, it is critically important to monitor your patient's electrolyte status, as these patients may run into cardiac problems from the loss of vital electrolytes. The recovery phase is where edema is decreased, the renal tubules begin functioning, and a fluid and electrolyte balance is restored within the body. A return of normal renal function is noted at that time, but it may take 6 to 12 months. Oftentimes, there's residual kidney dysfunction, such as the BUN creatinine may always be elevated if the damage was significant. It's very important to note if your patients had a history of acute renal failure and if their BUN and creatinine is elevated on a chronic basis, as this will drive treatment decisions in your patient when they're hospitalized. Acute renal failure clinical manifestations include pre-renal azotemia, where kidney injuries caused by poor blood flow to the kidneys result in high levels of nitrogen waste, so you have an elevated BUN and creatinine. The patient is oliguric of less than 500 milliliters of urine a day. The urine will have a low specific gravity as the kidney cannot concentrate the urine. The patient experiences nausea and vomiting, lethargy, headache, and muscle twitching. And also noted is hypotension, tachycardia, decreased urine output, decreased cardiac output, and decreased CVP. In the intrarenal or postrenal azotemia, there's oliguria and anuria of less than 50 milliliters a day. Risk for hyperkalemia and EKG changes are noted, tall T waves, hyperventilation as the renal system is failing to buffer the metabolic acidosis that's accumulating in the patient, and the respiratory system tries to compensate for this. The patient experiences hypertension, tachycardia, jugular venous distension, and increased central venous pressure. You'll also note as you assess your patient that they'll be short of breath, they'll have crackles in their lungs, and pulmonary edema. Additionally, the patient may experience nausea and vomiting, a change in loss of consciousness, edema, or weight gain. Nursing interventions in acute kidney injury. Acute kidney injury is a term that is synonymous with acute renal failure, and it just describes the process that's happening to the patient during this time. Pharmacologic therapy for the patient in AKI includes fluid boluses and diuretics, most often Lasix IV or as a continuous infusion. Calcium channels blockers are given as they relax smooth muscle, they vasodilate, and they improve glomerular filtration rate by improving kidney blood flow. Cation exchange resins, such as Kxalate, are often used. They can be given orally in the alert patient, NG in the patient with an NG tube, or by retention enema for those patients that are unresponsive. One of the risks of cation exchange resins is that there can be bowel ischemia, so this practice is actually going away. Another option for your patients in AKI is IV dextrose mixed with insulin. Most commonly, it's 5% dextrose, 1,000 liters, with 10 units of IV insulin or regular insulin added to the bag. And oftentimes, too, a calcium replacement is given. Albuterol can lower plasma potassium concentrations, but it also needs to be monitored as it can cause profound tachycardia. And then if patients are not responding to pharmacologic therapy, often hemodialysis is indicated. Nutritional therapies for these patients include a dietitian consult. Limited protein, as the protein molecules are large and as they accumulate in the body, they will make it difficult for the kidneys to filter them because of the large size of the protein molecules. You'll want to restrict fluids, sodium, potassium, and phosphorus intake, and provide high carbohydrate meals. If the patient is unable to eat for any reason, then total parenteral nutrition is started, often in the form of central venous nutrition or peripheral venous nutrition. Remembering that central venous nutrition offers an option for more calories as the concentration of dextrose in the solution can be run centrally. Other interventions for the patient in acute kidney injury include bed rest, monitor their skin, and asepsis to prevent infection. Diagnosis of acute kidney injury includes an abdominal X-ray to check the kidney size. A renal ultrasound is done to diagnose obstruction, stones, or dilation of the ureters. A CT scan without contrast dye will also diagnose obstruction or tumors. And remember, if kidneys are doing poorly, you would not ever want to give a patient any contrast dye, as they would not be able to eliminate it through the kidneys, and it can further cause issues with their renal failure. And if other options are not turning up anything, or a physician wants to look further, often a cystoscopy is done where a scope is inserted into the kidney structures, or a kidney biopsy if there's an unknown cause of what is happening or a tumor is suspected. Chronic kidney disease. Chronic kidney disease is a progressive, irreversible kidney injury. Kidney function does not recover, and 90% of the nephrons within the kidneys are destroyed. The first sign of chronic kidney disease is of renal failure and the kidney's inability to concentrate urine. They'll have a fixed urine-specific gravity of 1.010. Major risk factors for chronic kidney disease include diabetes, 36%, hypertension, 24%, glomerulonephritis, which is an infection, 11%, and then status of the patient themselves, African American, Hispanic, Native American, Asian, and then chronic inflammatory diseases such as lupus, rheumatoid arthritis, and AIDS. Remember, because diabetes is one of the main causes of chronic kidney disease, the United States is really making forth an effort to try and reduce patients' blood sugars and keep them at a target range of less than 80. Infection is the most common cause of death in renal failure, and remember, uremic syndrome is the inability of the kidneys to regulate the volume and the composition of body fluids. And if untreated, it leads to increased intravascular volume, acidemia, and an imbalance of potassium, phosphorus, magnesium, and calcium. This slide shows some of the clinical manifestations of chronic renal failure and renal insufficiency. They include headaches, edema, a glomerular filtration rate that progressively decreases from 90 to 30 milliliters per minute, mild anemia as the kidney releases erythropoietin to tell the bone marrow to make red blood cells, increased serum potassium, increased blood pressure, weakness and fatigue, increased BUN and serum creatinine, inability of the kidneys to concentrate urine, and polyuria progressing to oliguria. End-stage chronic renal disease indicates a GFR of less than 15 milliliters per minute and is manifested by psychological withdrawal, hematological anemia, increased serum potassium, dry, flaky, itchy, bruising skin, musculoskeletal cramps, bone pain, neurological weakness and fatigue, increased blood pressure, increased central venous pressure, a predisposition to pericarditis and congestive heart failure, arrhythmias, pulmonary shortness of breath, depressed cough, thick sputum, and an ammonia odor to the breath and metallic taste in the mouth. Chronic kidney disease changes. The cardiovascular system has complications that are associated with the uremia that is present in chronic kidney disease. These include hypertension due to the fluid overload, hyperlipidemia, congestive heart failure, as the increase in fluid overload produces a failure that increases the workload on the heart due to hypertension. Pericarditis, because the pericardial sac is inflamed by the uremic toxins or infection. And arrhythmias from fluid around the heart that result in cardiac tamponade and pericardial effusions. Respiratory complications include pulmonary edema or pleural effusions that may affect the lungs, crackles on auscultation, marked shortness of breath, Kussmaul's respirations, which are a type of respirations that slow up and speed up and slow down, and they're due to the respiratory system attempting to compensate for the decreased pH by increasing the rate and depth of breathing to excrete carbon dioxide. Musculoskeletal manifestations include osteodystrophy, or a lack of production of bone tissue, generalized muscle weakness, cramps, and bone pain. Nervous system involvement includes peripheral neuropathy, numbness, burning, sharp pain, muscle weakness, encephalopathy, brain damage, dysfunction due to the toxin buildup, mental status changes ranging from lethargy to coma, fatigue and tremors, slurred speech, and restless leg syndrome. Other effects of chronic kidney disease include hematologic effects of the uremia, which include an anemia in your patient due to the release of the erythropoietin, which tells the bone marrow to make red blood cells, and thrombocytopenia and platelet dysfunction, which result in abnormal bleeding or bruising. GI manifestations include ammonia, which is an odor to the breath, anorexia, nausea, vomiting, constipation, diarrhea, and GI ulceration or bleeding. The following labs show a decrease in the glomerular filtration rate according to the stage of the renal dysfunction. Stage 1 is a GFR less than 90. Stage 2 is a GFR from 60 to 89. Stage 3 is a GFR from 30 to 59. Stage 4 is a GFR of 15 to 29. And the last and most difficult stage is stage 5, which is a GFR of less than 15 mils per minute. Decreased creatinine clearance rates, a BUN that's elevated, a creatinine that's elevated, hypocalcemia, hyperphosphatemia, and hyponatremia. Oops, need to go forward. Serum creatinine. Serum creatinine is produced when protein or muscle breaks down. Creatinine is filtered by the kidneys and excreted in the urine. No common pathologic condition other than kidney disease increases the serum creatinine level, which is a wonderful thing because we're able to determine what's going on with our patients by watching their serum creatinines. It's the best indicator of kidney function, and normal levels for males are 0.6 to 1.2, and in females 0.5 to 1.1, remembering that it's a little bit higher in men than in women. Treatment or interventions for end-stage renal failure include the goal of controlling fluid and electrolyte balance, regulating the patient's blood pressure, managing their anemia, monitoring for peripheral neuropathy, nausea and vomiting, anorexia, congestive heart failure, encephalopathy, cardiac dysrhythmias, and fractures. Nutritional therapy is aimed at a renal diet which limits protein, possesses a fluid restriction of 5 to 800 milliliters a day, plus prior the day's 24-hour urine output. So if the patient has 400 cc's of urine output the prior day, then you add 5 to 800 milliliters of fluid, and that would be their fluid restriction for that day. Sodium, potassium, and phosphorus are also restricted in their diet, and you want to increase their calcium, increase their carbs, and increase their vitamin D. Pharmacologic treatment of end-stage renal failure includes calcium and phosphorus binders, so things like calcium carbonate or Tums, which bind to the phosphorus in order to eliminate it. Renagel is another calcium phosphorus binder that's often given. You want to make sure you're administering these types of medications with food. Your antihypertensive agents or your cardiovascular agents include diuretics such as Lasix, your calcium channel blockers and beta blockers for the hypertension, and then your inotropic agents, which increase that cardiac contractility, thereby increasing cardiac output. Digoxin or Lanoxin is given IV push or oral, and dobutamine or Dobitrex is given as a continuous IV infusion in these patients. Because patients often have problems with seizure and tetany, anti-seizure agents such as Valium or lorazepam or phenytoin are given to your patients. Erythropoietin or Epogen or Procrit is another type of medication that's given to trigger bone marrow production of red blood cells. This increases the hemoglobin and hematocrit and treats the anemia associated with renal failure. Erythropoietin is often given at IV at the end of dialysis or sub-Q, or iron sucrose, such as Venofer, or ferric gluconate, such as ferrolecit, may be used to promote an adequate response to the erythropoietin. Without adequate iron levels, the erythropoietin is not able to work. Here's another slide that talks a little bit about Procrit and its benefits. Hemodialysis. When clients can no longer be managed with conservative treatments such as diets, meds, and fluid restriction, patients will need to be managed with hemodialysis. Hemodialysis vascular access is achieved by a temporary device, an arteriovenous fistula, or an arteriovenous graft. And depending on the period of need for the hemodialysis will drive which type of vascular access is given to the patient. During dialysis, the patient, the dialyzer, and the dialysate bath require constant monitoring for complications. Medications, fluid balance, and nutritional needs must also be addressed. And the patient, if not watched closely, is at severe risk for several complications. Who needs dialysis? Remember the vowels, A, E, I, O, and U. A are your acid-base problems, E are electrolyte problems, I are intoxications, O is overload of fluids, and U is uremic symptoms. And in this case, we're talking more about our uremic symptoms. However, these patients also develop issues with overload of fluids, electrolyte problems, and acid-base problems. Acute hemodialysis is also entertained in the patient who has had an overdose of some type of medication. And so those are the patients that most often get a non-permanent vascular access site. If you notice on this slide, the hemodialysis, it shows that you have the vascular access to the circulation. Arterial blood is accessed and it goes through a blood pressure monitor where it goes through a pump and into the dialysis port itself. The dialysis fluid is drawn out and then is filtered, and then the dialysis fluid goes back in after it's filtered and goes back into the clot and bubble tract and back to the patient. In the dialysis filter itself is a semi-permeable membrane, and within this semi-permeable membrane, the impurities and the problems that the patient has in their blood are filtered out, and then the blood is cleaned and sent back to the patient. An artificial kidney, or a dialyzer, is that hollow fiber semi-permeable membrane that removes toxic nitrogenous substances from the blood and excess water. The dialysate solution circulates around the tubules of the dialyzer. The whole process of dialysis is based on several different types of water pressures. Ultrafiltration is an increased pressure that's used to remove more fluid. Diffusion removes toxins and waste in the blood particles from an area of high concentration in the blood to an area of low concentration in the dialysate. And osmosis allows the excess water to be removed by that process, which allows it to move from an area of higher solute concentration in the blood toward an area of lower solute concentration in the dialysate. Remember, these patients will need anticoagulation as the heparin keeps the blood from clotting in the dialysis circuit, and it remains active for 4 to 6 hours after dialysis. Again, here's another slide that shows how hemodialysis works. And if you notice at the very bottom on the right-hand side, it shows number 4, the vein, and number 1, the artery, and it shows the fistula. One needle is inserted into the vein, and the other is inserted into the artery of the fistula. The blood from the artery goes into the arterial pressure monitor, goes to a pump, and then if you notice number 2 there is a syringe. Heparin is added to the blood during this time before it travels to the dialyzer. Once in the dialyzer, the blood travels through to a pump where the dialysate filters the toxic waste substances out of the blood, and then the cleansed blood is returned back to the tubing circuit, goes through a venous pressure monitor, through an air trap and detector, and back to the patient. Hemodialysis access devices, there are several. There's a shunt, there's a fistula, and there's also a central venous access device. They're required for hemodialysis due to the large amount of blood flow and the rapid type of blood flow that goes through 250 milliliters or more over a 3 to 4 hour run. There's a very high pressure system when you access an artery. Therefore, the shunt or fistula or central access device has to be able to tolerate these larger pressures. Temporary vascular access devices, often known as a permacath, are inserted into a large vein or artery, often in the subclavian, internal, jugular, or femoral area. There are issues with the temporary vascular devices. It's prone to infection and thrombosis, and because of its temporary nature, it's smaller and less blood per minute can be filtered compared to internal devices. The advantage of the temporary vascular access device is it's helpful in times when patients won't need dialysis for a very long period of time, such as in drug overdoses and those types of things. If the patient is a chronic renal failure patient who's going to need dialysis probably permanently, then the arteriovenous graft or the arteriovenous fistula are more often used. The arteriovenous graft is a Teflon material tubing inserted between an artery and a vein in the forearm and then implanted. It can take about 4 to 6 weeks before this graft is strong enough and healed over well enough to be accessed, and it can leak after many accesses and does often clot. The gold standard for the patient who requires long-term dialysis would be the arteriovenous fistula. The AV fistula is where an artery and a vein in the forearm are surgically connected. They're less likely to clot or become infected. They're available for longer-term use, but they do take 4 to 6 weeks for the vein to engorge, and sometimes longer. Oftentimes, patients who need long-term hemodialysis will have a temporary vascular access device inserted to allow for dialysis while the arteriovenous fistula is healing. The arteriovenous fistula is accessed with 2 very large needles, and one of the things you need to make sure you're teaching your patients is that they need to check the site for a thrill where they can feel the blood moving through, and a bruit heard daily for patency of the site. This slide here shows several types of subclavian dialysis catheters. And if you notice that the red cap is for the arterial blood and the blue cap is marked for the venous access. The AV fistula is shown here, where it's formed by surgically connecting an artery to a vein, most often the radial or brachial artery to the cephalic vein on the non-dominant arm. The two are slit to the side, sutured together, and then time is needed for the fistula to mature and develop, and some may not be ready for up to 4 months. The AV graft shows the brachial artery, where a polytethalon graft, like a tube, is inserted into the vein and then inserted to the artery, which allows transmission of the fluids. Hemodialysis nursing care, nursing management. The nurse often wears face shield, gown, and gloves, as there's always potential for body and fluid exposure, especially blood. Baseline vital signs, lung sounds, and heart sounds are done, and it's critical to weigh the patient before the run to accommodate and understand how much fluid is being pulled off the patient during their dialysis run. Dietary and fluid restrictions include protein restriction, more liberal. Only high biologic quality protein is allowed, though, however. Eggs, soy, meat, milk, poultry, and fish. Sodium restriction continues, and fluid restriction again continues, equal to the daily urine output, plus 500 to 800 milliliters. Complications of hemodialysis include hypotension, which is the number one problem. As too much fluid is drawn off the patient, they often become hypotensive. Headache, nausea, vomiting, weakness, and fatigue. Dizziness, syncope, and vertigo, often due to the hypotension. Muscle cramps, bleeding at the access site or the dialyzer clotting. Dialysis disequilibrium syndrome, dysrhythmias, chest pain, and vital signs and weight are assessed after the procedure. Peritoneal dialysis. Peritoneal dialysis is where a siliconized radiopaque rubber catheter is surgically implanted into the abdominal cavity below the umbilicus. This catheter sits in the peritoneal cavity and allows for exchange of dialysate fluid back and forth across the gradient. Increased glucose concentration in the dialysate makes the solution more hypertonic, creating a greater pulling pressure for the fluid removal during the dialysis exchange. There are several different types of peritoneal dialysis. One is continuous ambulatory peritoneal dialysis, or CAPD, and this is done 4 to 5 times per day, 7 days a week. There's automated peritoneal dialysis, where a machine is used 8 to 10 hours a day. There's intermittent peritoneal dialysis, which is automated or manual 3 to 4 times a day per week. And then continuous cyclic peritoneal dialysis connected to a machine, usually at night. The automated peritoneal dialysis machine allows for the patient to hook themselves up, sleep during the night, and disconnect themselves in the morning, thereby allowing them increased liberty of activity during the day. The peritoneal dialysis exchange here shows the patient with the dialysate, which is a large bag of glucose. The glucose flows into the abdominal cavity, and the drainage bag is clamped for a period of time. While that dialysate sits in the abdominal cavity, it's high in glucose. It draws in lots of the impurities, and then after that, the drainage bag is opened and allowed to drain to gravity. Peritoneal dialysis exchange. Aseptic technique is imperative during peritoneal dialysis because of the number one risk of peritonitis, which is a very difficult complication of peritoneal dialysis. Infection at the access site and clot formation can also occur. 1 to 2 liters of warm dialyzing solution are infused by gravity into the abdominal cavity over 10 to 20 minutes. The solution is allowed to dwell for 30 minutes to 10 hours, and an equilibrium between the toxins, electrolytes, and fluid is reached. Nursing interventions for the peritoneal dialysis exchange patient include during dwell time to assess the client's lungs and abdomen. Because 2 liters of fluid are inserted into the abdomen, it pushes the diaphragm up, and oftentimes these patients have difficulty breathing. Constipation can also cause problems for instilling and draining the dialysate, as the full colon takes up space in the peritoneal cavity. The fluids, or the effluent, is drained by the gravity into a drainage bag, and you want to monitor the fluid color. Appropriate color of peritoneal dialysis exchange is clear to yellow, and it does not have cloudy, brown, or bloody particulate in it. If this is noticed, then this fluid needs to be collected and it needs to be sent to a lab for analysis, because oftentimes these are signs of peritonitis. Continuous ambulatory peritoneal dialysis shows this patient, again, hooked with a dialysate bag on top, and you can see the catheter that dwells in the abdominal cavity, and the catheter is clamped, and then when the patient is done with the dwell, they open the clamp and let it drain to gravity. Here, an automated peritoneal dialysis is shown, where 2 or 3 bags are infused at one time. They go through a pump, the solution is heated, it goes into the abdomen, and then it comes back through a patient drain into a weigh bag and then into a disposal container via the pump. Complications of peritoneal dialysis. Number 1 complication is peritonitis, infection from the connection site contamination, cloudy effluent, fever, abdominal tenderness, pain, nausea, and vomiting. And if you remember from Nursing 102, rebound tenderness of the abdomen is oftentimes a sign of peritonitis. So if you palpate their abdomen and you push down and the rebound causes a pain, that's a positive sign for peritonitis. And pain is common during the first treatment, as the abdominal cavity needs to grow used to having something foreign in it. Warming the dialysate bag helps to decrease the pain, and after a period of time, this should cease. Exit site and tunnel infections, signs and symptoms of infection. The catheter should be completely dwelled. You want to monitor for leakage, pulling, or twisting of the catheter. Poor dialysate flow is often due to constipation, and other causes include a kinked catheter, a clamping connection tubing, patient position, catheter displacement, or fibrin clot. And oftentimes, repositioning the patient or having them roll side to side will help get rid of the poor dialysate flow. Dialysate leakage. So oftentimes, there's clear fluid from the catheter exit site. It takes new patients 1 to 2 weeks to fully tolerate full dialysate 2-liter exchanges without leakage. So a little bit of leakage during the first week or 2 is normal, but if it persists past the 2-week period, then the care provider needs to be notified. This is a concept map of end-stage renal disease, and you will be able to review this on your own. Renal cell carcinoma. Renal cell carcinoma is often the adenocarcinoma of the kidney. Causes are smoking, chemical exposure to lead, phosphate, or cadmium hereditary. And it's of note to note that after about 1945-1950, lead paint was outlawed in all residences in the United States. But there still are many older residences that have lead in them. Metastasis of the renal cell carcinoma often goes to the adrenal gland, the bone, the liver, the lungs, the other kidney, and the brain. Assessment of these types of patients, you want to assess them for hematuria, flank pain or mass, fever, weight loss, anemia, elevated calcium, liver dysfunction, increased SED rate, increased liver enzymes, and elevated blood pressure. Paraneoplastic syndrome includes cancer-fighting agents of the immune system attack the neurosystem or muscle cells and produce difficulty walking and difficulty speaking. Nursing management of the patient with renal cancer include measuring hourly output to maintain an output of greater than 30 to 50 mils an hour, watch for abdominal distension and bleeding, watch for hypotension, decreased urine output, altered level of consciousness, monitor electrolytes, temp, white count, hemoglobin, and hematocrit, and to weigh the patient daily and turn cough and deep breathe hourly. Non-surgical management of the patient with renal cancer includes radiofrequency ablation, chemotherapy, and radiation. And newer targeted therapies out there are Toracel, Nexivar, which are oral drugs to slow cancer cell growth division and inhibit blood vessel growth within the tumor. If these are unsuccessful, then the patient is scheduled for a nephrectomy to remove the problematic kidney. And this slide also shows the typical stages of renal cancer. In stage 1, the tumor that's shown is a 7-centimeter tumor. Stage 2, the tumor has progressed to almost a 9-centimeter tumor. And in stage 3, the tumor has now developed a fascia and has invaded the vena cava. And in stage 4, it's invaded the vena cava, and parts of the kidney, parts of the tumor have broken off and metastasized to the lymph nodes. Kidney transplantation. Kidney transplantation is cheaper than continued dialysis, but Medicare today still doesn't usually pay for kidney transplants. Candidate selection criteria for kidney transplantation include that the patient be free of medical problems that increase the risks of the procedure. For example, chronic diabetes mellitus, cancer, alcoholism, or chronic obstructive pulmonary disease. Any other accompanying disease or comorbidity increases the risk of the medical procedure in a transplant. Individually, the patient up to 70 years of age can be considered for a kidney transplant, and then on an individual basis based on comorbidities and other health history in the patient. The donor for a kidney transplant has to have a matched ABO blood type, has to have matched tissue histology, and WBC cross-match and lymphocyte. The client's own kidney cannot be removed unless it's infected. Dialysis is usually needed for a period of time after the transplant to allow the patient to develop their own rhythm. And the transplanted kidney is placed in the anterior iliac fossa. Here this slide shows that oftentimes the actual kidney of the patient is not removed unless it's infected, and the other one is just inserted alongside of it. Postoperative management of the kidney transplant patient includes urologic management, hourly outputs of greater than 30 cc's an hour, and daily weight. Number one complication of postoperative management of the kidney transplant patient includes infection, and it's the number one cause of death during the first year following the kidney transplant. Thrombus is another issue, especially the major renal blood vessels that may occur during 2 to 3 days after the transplant. A sudden decrease in urine output would warrant an ultrasound of the kidney to detect if this is a problem. Another complication is renal artery stenosis. The patient develops hypertension and a bruit over the artery and an anastomosis site. It's a narrowing of the renal artery due to the surgical manipulation during surgery. This results in decreased kidney function, and you need a renal scan to detect blood flow, and it involves a surgical repair if it's detected. Post-kidney transplant rejection signs. Another major complication of kidney transplant is rejection of the organ. In hyperacute, the patient develops an onset of the rejection within 48 hours. They have malaise, high fever, graft tenderness, and the organ has to be removed due to the signs and symptoms. In acute, it happens 1 to 2 years after the kidney transplant, and it's where the kidney develops oliguria or anuria, increased temp, elevated blood pressure, flank tenderness, lethargy, increased BUN and creatinine due to the inability of the kidney to filter anything, and fluid retention. And chronic kidney rejection is gradual over months to years and results in an increased BUN and creatinine as imbalances in proteinuria, electrolytes develop, and the patient experiences fatigue. Rejection of the transplant generalized signs and symptoms include decreased urine output, increasing edema, fever, increased blood pressure, increased weight gain, fever, chills, swelling, and a tender kidney, increased BUN and creatinine, and increased white count. And again, we've talked about the hyperacute, the acute, and the chronic. It's difficult to tell if the rejection or infection is happening, so oftentimes they need a renal biopsy. And the treatment for acute rejection is increase the immunosuppressive dose. And for chronic rejection, oftentimes the transplant will last approximately 10 to 15 years. Medications that are given to help reduce rejection are your ones. your prednisone, your cortisone, and your dexamethasone. They're the #1 anti-inflammatory corticosteroids. They all end in ONE, and these are our kidney transplant rejection drugs that are used. So the medications that are used in rejection are the immunosuppressive drugs, and you want to start these before OR. Multiple drugs act on different components of the immune response and have synergistic effects. In other words, they work together, and they usually cause less severe side effects when given in tandem. Corticosteroids such as prednisone lower T cells and cause antigens, so they do not produce an immune response. One of the side effects of corticosteroids is that they put the patient at high risk for infection, so you want to monitor for sore throat, fatigue, malaise, and increased temp. Cyclosporin, or NUR, is a microemulsion form that delivers medication reliably, producing a steady state serum concentration, but it's very expensive. One of the problems with cyclosporin is it's nephrotoxic 2 to 3 months after initiation. You want to monitor the BUN, the creatinine, the INO, and the weight. Additionally, you want to administer at the same time each day and monitor potassium levels, as this drug can increase the potassium level. And also, these drugs are monitored for cyclosporin levels in the blood. Other medications used are monoclonal antibodies. Those are used to suppress the rejection, and their generic names end in MAB. Baxilmab and daclizumab are 2 that are used. And then your polyclonal antibodies act mainly against the T lymphocytes, the ATGAM, the CellCept, and the Rampune, and the tacrolimus. And these are more potent than cyclosporin, so you want to remember to take these on an empty stomach, monitor blood levels, monitor renal function, and again, these drugs can cause increases in potassium. Case study. The case studies that are present in the slides will be covered during the lecture portion in class. Renal trauma. The most common renal injuries are contusions, lacerations, ruptures, and renal pedicule injuries, or small internal lacerations. Even a fairly small renal laceration can produce massive bleeding. The goals of management are to control hemorrhage and pain, prevent infection, as well as to preserve and restore renal function. Remember, the vascular nature of the kidney itself lends itself to being a very major organ that has issues with bleeding within the abdominal cavity. Here, this slide shows several different types of injuries that may happen to the kidney. On the top, you'll note that an expanding hematoma may cause a rupture, extravasation, or an exsanguination of the patient. A contusion is located within the kidney and is usually localized to the kidney itself. Oftentimes, a contusion can lead to bleeding into the collecting system and shock, and a laceration is an actual opening up of the kidney itself. A pedicule injury may cause ischemic necrosis of the kidney as it shuts off blood supply to the kidney itself. And one of the major manifestations of kidney injuries, for the most part, are microscopic blood in the urine, such as a dark amber urine or frank blood noted in the urine. Renal trauma clinical manifestations. Pain. These people have a lot of pain. As blood is put into either the urinary system or the peritoneal cavity, the patient develops pain quickly. Renal colic may be happening depending on the source of the injury. Hematuria is the most common symptom that you'll see. And you may also notice a mass or swelling in the flank. Ecchymosis is noted in the patient, a gray Turner sign of the flank, or a Cullen sign of the periumbilical area, and both of these are associated with a retroperitoneal bleed. Lacerations of wounds of the lateral abdomen or flank are also noted in renal trauma. This slide here shows a positive Cullen sign where the periumbilicus is discolored from the bleeding into the abdominal cavity. Nursing management of these patients includes monitoring for signs and symptoms of hemorrhagic shock, monitoring for associated injuries such as liver, spleen, abdomen, and adrenal gland injuries, aggressive fluid resuscitation, surgical removal of kidney if necessary, nephrectomy, and not mentioned here, but also another thing to consider is that if the patient is bleeding profusely, you may want to transfuse, hopefully with type-specific blood, but in the case of a true trauma where you wouldn't have time to type, you may have to use ONEG. Polycystic kidney disease. Polycystic kidney disease, or PKD, is an inherited disorder in which fluid-filled cysts develop in the nephrons. Signs and symptoms of polycystic kidney disease include abdomen or flank pain, hypertension, nocturia, increased abdominal girth, constipation, kidney stones, bloody or cloudy urine, and 50% of these patients develop renal failure by age 50 and need a kidney transplant. The assessment is done with a renal ultrasound, a CT, or an MRI. This slide here shows the different types and how this looks. Slide A is the little cysts, and slide B is where those fluid-filled sacs have actually ruptured. And one of the problems with polycystic kidney disease is that as the numerous amount of cysts develop in the patient, they eliminate the ability of the kidney to function. Interventions. You want to manage acute and chronic pain, prevent infection by giving antibiotics such as Bactrim, Septra, Timprex, or Cipro. These enter the cyst wall and allow for antibiotic therapy to be effective. It is not appropriate to give non-steroidal anti-inflammatory drugs to these patients as they reduce kidney blood flow. You want to avoid aspirin in these patients to reduce their risk of bleeding, prevent constipation by increasing fluids, fiber, and exercise, and strict blood pressure control, managing their blood pressure with antihypertensives such as ACE inhibitors, which increase renal flow, or calcium channel blockers or vasodilators. Diuretics may be needed if the blood pressure remains high, and if there's large cysts, needle aspiration to remove the toxic fluid from the cysts. Hydronephrosis, hydroureter, and urethral stricture. These are all problems of urine outflow obstruction. Hydronephrosis is an obstruction in the upper part of the ureter, and the kidney enlarges as the urine collects in the renal pelvis and the kidney tissue. And if you note here, there's a stone, and then that causes an actual swelling up above the side of the stone and into the kidney. A hydroureter is an obstruction in the lower part of the ureter, where the ureter enlarges rather than the kidney. You can notice the stone is down lower in the renal tubule, or the ureter, and what's happening here is that the stone obstructs flow and the ureter enlarges. Hydronephrosis, hydroureter, and urethral stricture. Hydronephrosis is an obstruction in the upper part of the ureter. Kidney enlarges as urine collects in the renal pelvis and the kidney tissue. Distension, increased kidney pressure, and extensive damage to the kidney tubules results of this. In hydroureter, the obstruction is in the lower part of the kidney, and the dilation occurs above the obstruction and enlarges as the urine collects. In urethral stricture, the obstruction is very low in the urinary tract, and it causes bladder distension before hydroureter and hydronephrosis. This is rare in women and happens more commonly in men due to an enlarged prostate. These conditions are dangerous when nitrogen waste products and electrolytes are retained and acid-base balances are developed. Causes of hydronephrosis, hydroureter, and urethral stricture include tumors, stones, trauma, structural abnormalities such as birth defects, fibroses and scar tissues due to radiation or surgery, cancers of the bladder, prostate, and issues with the uterus due to pregnancy. Interventions include a urology consult, a renal ultrasound and CT scan to diagnose the actual issue, a cystoscope or a retrograde urogram procedure to remove stone and place a stent, or a nephrostomy, which diverts urine externally and prevents further kidney damage. The nephrostomy tube remains until the obstruction is resolved, and you want to monitor the patient for signs and symptoms of back pain, which may indicate a dislodgement or clogging, drainage, which is normally red-tinged at first for 12 to 24 hours, and signs and symptoms of infection, fever, change in urine character, and any other types of signs of infection. Pyelonephritis. Pyelonephritis is a bacterial infection in the kidney and renal pelvis of the upper urinary tract. And causes of pyelonephritis are most commonly a untreated urinary tract infection that develops reflux upwards into these organs. Hydronephrosis, pregnancy, bladder atony, renal calculi, overuse of non-steroidal anti-inflammatories, and urinary tract infections. Signs and symptoms include fever, chills, tachycardia, tachypnea, flank, back, or loin pain, abdominal discomfort, nausea and vomiting, urgency, frequency, burning on urination, nocturia, and general malaise or fatigue. Diagnostic assessment of the patient includes a urinalysis, keeping in mind that a positive leukocyte esterase is the most sensitive indicator for a urinary tract infection. Nitrates are present in the urine, White blood cells are often present, and also are bacteria. It is important to remember that in these patients, if at all possible, you want to do a catch specimen rather than a clean catch to make sure that the white cells and bacteria that are present in the urine are accounted for due to the infection and not from the actual urinary collection itself. Cultures and sensitivities are important as you want to identify the underlying bacteria that's present, whether it be E. coli, Enterococcus faecalis, Staph aureus, Klebsiella, Candida, or Salmonella, as antibiotic therapy will be driven by the type of bacteria identified in the infection. An X-ray, a kidney, ureter, bladder, or a KUB, and an IV urography to diagnose stones or obstructions. Pyelonephritis treatment includes surgical shockwave lithotripsy, pyelolithotomy, which is stone removal from the kidney, a nephrectomy, which is a removal of the kidney, a ureteral diversion or reimplantation of the ureter to restore proper drainage. Non-surgical includes 2-week course of antibiotics, broad-spectrum antibiotics, and then narrow-spectrum antibiotics according to the urinalysis culture and sensitivity. Some of the common antibiotics that are used in these types of patients are TMP and SMZ, ciprofloxacin, gentamicin, ampicillin, or third-generation cephalosporins. Urinary antiseptic drugs such as macrodantin or pyridium are often given, and pyridium also helps to decrease pain in these patients. Monitor INO, BUN, and creatinine, increase fluids, monitor for sepsis, tachycardia, hypotension, and an increase in fever. It is important to note that untreated urinary tract infections that develop into pyelonephritis can become one of the most common causes of sepsis in any patient. The vascular system of the kidneys is large, and because of the ability of the blood flow that goes through there with an infection, it can take the infection to other parts of the body, creating a sepsis quickly. So these patients need to be watched carefully. And some of the causes of pyelonephritis are kidney stones. If you note in this picture here, it shows simple stones that are too large to pass through the ureters. They need to be shock waved. The ultrasound waves shock those stones and crush them up where they're in smaller pieces and they can pass out of the body. And here's a slide that kind of shows the microbial invasion of the renal pelvis, how it produces an inflammatory response, which results in fibrosis of scar tissue, decreased tubular reabsorption and secretion, and permanent impaired renal function. Again, the case we will class.